Good morning, everybody. It's my pleasure to be part of the Sao Paulo HIV Clinical Forum 2021. I want to thank the organizer for inviting me to be part of this important meeting. My task today is to discuss, as you can read in the title, dual therapy with Dolutegravir and Lamivudine. Do we need more evidence? These are my disclosures. And these are the challenges that I can identify regarding Dolutegravir 3TC in treatment-naive patients. Is the results durable? Efficacy in patients with high viral load and CD4 T cell count has been demonstrated. What about more sensitive viral markers, by example, target not detected? Is the frequency of LIPS the same with Dolutegravir 3TC versus Dolutegravir-based 3-drug regimens? Is the rate of type 2 virological suppression the same? Is the barrier to resistance to Dolutegravir 3TC high enough? What about safety and tolerability? And what do we know regarding the use of dual therapy with Dolutegravir 3TC in pregnant women, children, and TB co-infection? The point is that we now have very efficacious regimes, as you can see, in the order of above 90% efficacy. And this happens to be true with dual therapy and with triple therapy. So the point is that in the next future, we shouldn't expect to have regimes that provide us higher levels, higher than 94, 95%. So the point is that we are trying to simplify treatment as much as we can in order to make our patients' life easier. Just for the sake of comparison, look, I'm showing you here the results that are above 90% efficacy. And for the sake of comparison, look at this box in which you can see the results of the 006 study that gave birth to the Favirenz with, in that time, combined with Zidovudine and 3TC, with just 64% efficacy. So from 64% efficacy, we are now in the range of 90 to 93%, and this is very important to keep in the back of our minds. So why would we try to reduce the drug burden in our population? First, to address the needs of our aging population. As you know, not only physicians are becoming older, also our patients. My patients that I started assisting when they were 30 years old are now probably 50 years old and suffering the issues of aging and comorbidities. We try to reduce the antiretroviral exposure, making treatment safer without sacrificing virological control. We want to reduce the pill burden and so improve patient adherence and improve their quality of life. Also, the less drugs you use, you will carry the risk of less drug-drug interactions. It's possible to try to reduce costs, not always true, and we have a potential for long-term success. Just think about if you start with dual therapy and something goes wrong, you still have a spared class in case of first regimen failure. This is a poll that was done a couple of years ago among about 1,000 patients that were asked about what were their concerns in regards to long-term effects of IRT. And as you can see in the first row, reduced long-term effects of HIV medicine on my body was the most frequently answered question. And fewer adverse events and take less HIV medicine were also ranked highly. No? So obviously this is a very important point because it's the point of view of our patients. Patients want to have their viral load undetectable. They want to recover as much as they can their CD4 counts, but they don't want to pay the toll of side effects and toxicity. So the question that we posed originally when we started developing dual therapy was, is highly active antiretroviral therapy about number of drugs, or is it about potency and safety? So the rationale, as I said, is the bottom line is that HART is a lifelong treatment. Current regimens are carrying a high efficacy, as I showed you. There are several approaches aimed to simplify HART, and one of them was monotherapy, but monotherapy failed to show non-inferiority in antiretroviral naive patients. On the other hand, 3TC is the most frequently prescribed antiretroviral in the last 30 years. It's a cheap drug, extremely well tolerated. It has become generic, so it's really cheap, and it's still active even in the presence of the M184V mutation. So we decided to do our first dual therapy study with lopinavir, ritonavir, and 3TC. At that time, lopinavir, ritonavir was the main protease inhibitor in our practice. And as you can see here, we compared lopinavir, ritonavir plus 3TC against lopinavir, ritonavir plus 2 nucleosides, and the results showed non-inferiority at 48 weeks for the primary endpoint that was viral load less than 50 copies. At week 96, it was maintained for those patients that agreed to be part of the second year of the study, with a difference of 10 points in favor of the dual therapy arm, which doesn't mean that dual therapy is better than triple therapy, but anyway, non-inferiority was shown. And if we go to a more stringent outcome, patients with a baseline viral load above 100,000 copies, you can see here that again, non-inferiority was shown. So based on that, we decided another study using darunavir, ritonavir, a more contemporary PI, associated with 3TC. And as you can see here, in all patients and in patients with more than 100,000 copies, similar numbers in terms of results were obtained, 93 and 94, and 91 and 92 respectively. So the point was proven not only with lopinavir, ritonavir, but also with darunavir, ritonavir, in both cases associated with 3TC. And then we decided to study dolutegravir and 3TC. Our first shot was to try to prove the concept in a very carefully designed study in which we included 20 patients, a first cohort of 10, a second cohort of another 10. And what you see here is the screening basis, the screening values of viral load, the baseline values of viral load. And as you can see, albeit the inclusion criteria was less than 100,000 copies to be included, we had 4 patients with more than 100,000 copies that you can see here in red. Anything that you see here in green means less than 400 copies. What you see in yellow is less than 50 copies. So as early as day 4, we had some patients with less than 400 copies. As early as day 7, we had some patients with less than 50 copies. But eventually, all patients by week 8 had less than 50 copies, and this was maintained until the end of the study at week 96, except for 2 patients. One patient passed away for an unrelated severe adverse event, but he had less than 50 when he has his last control, and one patient had what was defined as protocol-defined virological failure. That means having 2 viral load above 50 copies consecutively after being undetectable. This patient eventually resuppressed with the same regime, but for the sake of the protocol, it was considered a failure. So we have 90% in the intention to treat analysis efficacy, and in the observed data, 95%. So based on our results, the ACTC group designed the ACTC 5353 trial, in which they included, instead of 20, it included 120 patients. And instead of having a seeding of 100,000 copies, they used a seeding of 500,000 copies. And as you can see here, the results in both populations, above 100,000 and below 100,000, the success rate was very similar, 89% and 90%. The concerning issue was that they had 3 patients with protocol-defined virological failure, but one patient had an emergent resistance for 3TC, the M184B, and one patient selected the 260C-RK, which is a mutation for dolutegravir. So this, in some way, has put a question mark, what would happen if we have a larger trial? Finally, the larger trial came across, and as you can see here, we studied 1,400 patients, 700 and something in each arm, and at any time point, week 12, week 24, the primary endpoint that was at week 48, 93% versus 91.5, at week 96, and later on at week 144, there was non-inferiority was demonstrated in a consistent manner at the snapshot analysis. As you can see here, this is week 144 results for Gemini 1 and Gemini 2. There are 2 sister studies that were run at the same time. For the pooled results, 82% of the patients at week 144 had viral load undetectable below 50 copies, and 84% in the triple arm. As you can see here in the pooled results, the confidence interval crosses 0, so there's no inferiority that has been demonstrated. The interesting point is that as of week 96, no treatment emergent resistance was observed among patients who met the confirmed virological withdrawal criteria, that in this case was more than 200 copies confirmed in two separate plasma viral load. So 0 treatment emergent resistance in Gemini 1 and Gemini 2 for each of the arms. If we go to the snapshot analysis again, as you can see here, 82% versus 84%, and most of the cases that were not a window for the snapshot analysis were patients that had other issues because they discontinued because of adverse events, they continued for other reasons, and were studied but had missing data in window. Interesting, of the patients that met confirmed virological withdrawal criteria, 12 were in the group of Dolutegravir 3TC, and 9 were in the group of triple therapy. No participant with confirmed virological withdrawal had treatment emergent resistance either for integrase inhibitors or for nucleosides. There was one patient in the Dolutegravir 3TC arm that didn't comply with the confirmed virological withdrawal criteria, reported non-adherence, and developed the M184V at week 132 with a viral load of 61,000 copies, which means that the patient was not adherent to treatment, and the 260C-RK at week 144 with a viral load of 135. That means that the patient started again to treat, to use the treatment medication. The result was a 1.8-fold change in dolutegravir susceptibility. The patient regained virological suppression after switching to dolutegravir QD and darunavir covistat after week 144. So this was not a real case of true virological failure, but nevertheless, there was a selection of resistance in patients that is not adherent. And regarding safety, weight gain, and virological response, compared to baseline parameters, there was significant lower risk of drug-related adverse events with dual therapy compared with triple therapy, 20% versus 27%, with a 24% reduction in the relative risk. There was more weight gain in the dual therapy arm compared to the tenofovir FTC dolutegravir arm, and this is probably due to the fact that we know that tenofovir in some way helps you to reduce weight when compared to a regimen without tenofovir. We have seen this situation when patients were switched from tenofovir to TAF, the same results were seen. So the main weight gain after the 144 weeks was 3.7 kilograms in the dolutegravir 3TC arm versus 2.4 kilograms in the triple therapy arm. Regarding the analysis by subgroups, as you can see, having high viral load does not influence at all the results that you can obtain. But in patients with less than 200 CD4s, you see low numbers in both groups. And this difference is due to the issue that in our studies, you can see that patients with less than 200 CD4s, the results are poorer when compared to patients with higher levels of CD4s. In this case, the numbers are very, very small in order to establish statistical significance. But the important point is that this has been understood by the regulators. And for instance, the DHHS guidelines don't put CD4 count as a limitation for using this dual therapy combination. What about the intrinsic potency that you can see in this combination? If you look the viral decay, the speed of viral decay and the slope of viral decay, and you compare the dolutegravir 3TC with the dolutegravir tenofovir FTC, as you can see, the curves are here superimposed. So the level of decrease in viral load and the speed of that decrease is really important to see that there is no difference between arms. The type of virological suppression, a different way to see the same phenomena, as you can see here, is the curves are again superimposed. So there are no difference in secondary viral load decay up to 500,000 copies. In regards to blips, there's no difference between arms, as you can see here. In blue, dolutegravir 3TC, in orange, dolutegravir plus tenofovir FTC. So the cumulative occurrences are very similar, 87 blips seen in the dual therapy arm and 109 in the triple therapy arm. Obviously, there were higher numbers with higher viral load in the triple therapy arm, but the important thing is there's no major difference, so you are not risking to having more blips when you use dual therapy compared to triple therapy. And if you go to your virologist and you ask him to tell you what is in regards to target not detected, usually our virologists, they tell us that our patient has less than 40 copies if they are using the Abbott method, or less than 20 copies if they are using the Amplicor. But anyway, they can go further and tell us if the target is detected or not. And the level of target not detected in the overall period in patients with less than 100,000 copies, or eventually in patients with more than 100,000 copies, you can see here there's no statistical difference between arms. So the deeper response, achieving target not detected, is similar in both groups. And as you can see here, this is not difference if you look at less than 100,000 copies, more than 100,000 copies, more than 200 CD4s, or less than 200 CD4s, confirming that regardless of level of viral load on CD4s, dolutegravir 3TC is working as a very effective heart strategy. So again, as you can see here, dolutegravir 3TC and dolutegravir tenofovir FTC have a low number of patients meeting confirmed virological criteria. There was that one patient that I already told you about, and this patient was a case of non-adherence to therapy that was reported. So it's important to know that 0 participants developed treatment-emergent resistance across both treatment groups, except for this one that was a non-adherent patient. Safety and biomarkers, again, as you can see here, have a significant lower risk of drug-related adverse events compared to the triple therapy arm, 0.76, as I show you. Weight change was already discussed. And post-baseline changes in markers of renal and bone function favor the dolutegravir 3TC up to week 144. Without being statistically significant, nevertheless, they show the more favorable profile to dual therapy compared to triple one. And just to add some information in regards to dual therapy, in this case, we are talking about a study that did not enroll naive patients. They enrolled patients that were already undetectable, that were on a tough-based regimen. And the primary endpoint in switch studies, as you know, is not patients with less than 50 copies, but patients that have viral rebound above 50 copies. And as you can see here, 0.3 and 0.5% respectively were the results in the primary endpoint, and in the secondary endpoint, 93% in both groups remained with less than 50 copies. So also in a switch strategy, as you can see, this dual therapy strategy works very well. So I think that I have addressed all the questions that I posed. All the questions that I posed at the very beginning, except for this one, which is in red. We don't have enough data regarding pregnant women. We don't have enough data in children or in patients with TB co-infection, in which, as you know, you need to duplicate the dose of dolutegravir. So probably the question would be, if I have a patient that has been treated with dolutegravir 3TC and he acquires active TB and needs to be treated with rifampin, probably I need to add a second pill of dolutegravir at the evening, having taken the dual therapy pill in the morning. But for women and children, and particularly pregnant women and children, we don't have enough data so far to recommend this strategy. And just to give you a little bit more of context, be reminded that there are several other examples of dual therapy. For instance, this one, in which Atlas and Flare is a study in patients with naive situation. In Atlas is a switch study using cabotegravir and rilpivirine, injectable, but anyway, this is another example of dual therapy compared to oral heart, and you can see there's no difference in terms of the primary endpoints and also in regards to the secondary endpoints. So there's no difference when you compare Atlas and Flare. In Atlas and Flare, cabotegravir and rilpivirine dual therapy injectable versus continued oral triple heart. And there are other examples. For instance, now we are studying islatravir, which is a novel compound with dual mechanism of actions associated to doravirine, and the phase 2 trial results through week 48 are very encouraging in terms of the proportion of patients that are able to achieve less than 90%, less than 50 copies. As you can see here is about 90% results, particularly with the lower doses. And this drug, islatravir, is now being used, also being studied in association with lenacapavir, another novel mechanism of action, a Gilead drug that in combination with islatravir could also widen the scope of the current options for dual therapy. So dual therapy plus CBTC has shown rapid and potent antiviral activity with high barrier to resistance, with a long binding to the wild-type integrase inhibitor enzyme, with low likelihood of drug-drug interactions, very well tolerated, with promising dual therapy data in several clinical trials, and with a long half-life and lower variability in exposure. So this makes the Dolutegravir and 3TC an interesting option for naive patients. So in conclusion, two drug regimens are challenging the current 3R regimens. We don't expect to replace triple drug regimens, but yes, to have a different option for our patients. The strongest data that we have are based on Dolutegravir and 3TC, and less frequently with Dolutegravir and Lamivudine only for switch, which I didn't show due to the sake of time in this presentation. We have also data with boosted PI and 3TC in naive and switch patients, but with some caveats, particularly the issue that you need vaccine-resistant testing and HBV co-infection are not, patients that are co-infected with HBV are not eligible for this strategy. The same happens with Dolutegravir and 3TC, but we have more side effects and drug interaction when you use PI. So I think that Dolutegravir 3TC is for now the preferred dual therapy combination. And we have, as I told you, different emerging treatments with dual therapy. Current guidelines, both in DHHS, EX in my country and in several other countries, are included as an option for starting treatment. And as I said, more research is needed now in pregnant women, children, and patients who are infected with tuberculosis. And with that, I thank you very much, and I'm ready to take questions if needed.